Everyone, and thank you for being with us today. Welcome to the BRIE Collaborative webinar, Identifying Health Disparities, Striving for Health Equity. I am Amy Etzel, Implementation Manager with the BRIE Collaborative. Thanks for taking time today during a disorienting week within an even more disorienting time in history. As some of you know, I often lean on quotes of people smarter than I to try and help me make sense of these strange times. And this quote from James Baldwin has been on my mind lately as we all work toward a better understanding of equity and our own roles within this work. Words like freedom, justice, democracy are not common concepts. On the contrary, they are rare. People are not born knowing what these are. It takes enormous and, above all, individual effort to arrive at the respect for other people that these words imply. This topic of diversity, equity, and inclusion feels even more important as we as a country and healthcare community continue to face these recurring and multiple crises. And we appreciate you taking the time today to learn with us and bring visibility to these issues of structural racism and implicit bias within healthcare and our systems. Before we begin, just a few housekeeping items of note. This webinar is being recorded. I will be sending all of you a link to the recording of today's event and a copy of today's slides before the end of the week, along with some relevant resources and future learning opportunities related to diversity, equity, and inclusion. You may have noticed the closed captioning transcription at the bottom of your screen. In the spirit of inclusivity, the BRIE will be using this feature in Zoom for all meetings going forward. If you would like to view and read the full log of this transcription, please look to the bottom of your screen and click on the far right option, View Full Transcription. The second option of the menu that will appear is View Full Transcription. This will bring up a dialog bar on the right side of your screen with a log of the transcription, should you like to refer back to anything. As I mentioned, you're all currently on mute and you will be throughout the webinar. During our presentation, please feel free to write questions into the Q&A box located at the bottom of your screen. Please enter questions for our speaker into the Q&A box and any technical issues you may be experiencing into the chat box. There are also Zoom instructions attached to the meeting invitation sent out this morning with some visual images and notes on how and where to find this Q&A box and the chat box. We will be monitoring both, but we'll be looking primarily at the Q&A box for questions at the end of our time together. But feel free to submit questions throughout the time. We will just address them at the end. We do have some polling questions throughout the webinar, so please participate in those as they come up. All right, that ends housekeeping, so let's dive in. Today, we are extremely lucky to have Michael Garrett with us, Principal, Total Health Management and Inclusive Benefits Practice with Mercer. Michael has more than 30 years of experience in healthcare and has held a variety of roles ranging from case management to healthcare quality. His work at Mercer involves optimizing clinical management programs, selecting and implementing new benefit programs and digital health solutions, and accelerating diversity, equity, and inclusion, DEI, through benefits. He has served as an author, editor, and contributor on case care management books, as well as the author of numerous journal articles in the field of care and case management. All right, Michael, take it away.
Great. Thanks, Amy, and thanks to the BRIE Collaborative for having me speak today. Hopefully you can hear me all right.
Yes.
Great. So let's see. This is me, Michael Garrett. I use he, him, his pronouns. I also, whenever I talk about diversity, equity, and inclusion, I also just like to mention that I'm on my own learning journey around diversity, equity, and inclusion. I bring to this presentation my own white cisgender male privilege and ability privilege and college education and housing and all that privilege. And so I have my own lived experience. I'm not an expert on every aspect of DEI. Again, I'm on my own learning journey, and I hope you all will as well. When Amy approached me about this, I also have an eye towards implementation, and I'm going to spend the first part of this presentation on background, terms, concepts, and so forth. And then trust me that I will come to some frameworks for implementation that could assist you in your organization in approaching health disparities and health equity. One of the other challenges in preparing this presentation, I know we have very diverse audience representation. We have healthcare providers, health systems, health plans, and employers. And so some of the comments that I will be making will be more relevant to some participants than others. I've been doing most of my work around DEI through benefits, meaning employee benefits, but also in some other areas as well. So we already did introductions. We're going to do an overview. We're going to do some framing of individual and organizational spectrums around DEI to figure out where we're all at, and then some implementation strategies, and then ending with some health equity resources that will be in the deck that you will be getting at the end of the presentation. So this is a colorful, maybe a bit busy slide that shows diversity, equity, and inclusion through all its domains. This flower in the middle kind of shows all the different kinds of individuals there are. I'm going to talk in more detail about that later. We at Mercer have found that folks have really varied in terms of where they're focusing. And so we thought today we would love to have you answer this question. Please select all that apply. About where are you spending your time on DEI organizationally? There's no right or wrong answer. And it varies a bit with the organizations I have worked with, both healthcare organizations and non-healthcare organizations.
We're getting lots of participation. This is great. Thank you all.
That's great.
So we're coming up on just a minute. Maybe we'll give people another 15 seconds.
Yep, that sounds good. Okay.
All right.
So I see race and ethnicity was the top vote getter. Socioeconomic status was second, followed closely by gender. I think maybe, I'm not sure if everybody saw that there were some down below. My experience has been race and ethnicity tends to be the most prominent with the clients I work with. Next would be probably people with disabilities, and next would be LGBTQ. But it varies by industry and the organization on where they're focused and what their prioritized populations are. So again, no right or wrong answers. I appreciate that that you responded. So I think historically, and particularly in human resources and maybe other areas, the focus has been on diversity. It's been more of a compliance approach to DEI. And I really see that organizations, in light of the racial and social justice issues that have gone on this year, have realized that they can't just stop with a compliance perspective with diversity. They have to achieve that inclusivity, which is a sense of belonging. The way I talk about this is diversity is asking someone who's not like you to the party, but inclusion is like asking someone who's not like you to dance at the party. So this idea of belonging to the group, participating and so forth, and particularly employers of any kind realize that it's attracting and retaining a diverse workforce. And in some instances, the retaining part has been challenging for employers. And I think in order to retain a diverse workforce, you have to have a cultural change that addresses inclusivity. And here we go. There's a number of things that are driving DEI. The Black Lives Matter movement, gender parity has been a big issue. The global pandemic, I think there's been a realization, particularly when we talk about health equity, that marginalized populations have been disproportionately impacted by the pandemic. I think our younger colleagues, Gen Z, millennials, want organizations that embrace the full scope of diversity, equity, and inclusion. And even if those individuals, those younger individuals, are not part of those marginalized populations, they want to work for an organization that addresses all the needs. And healthcare and benefits are part of it, financial and other aspects as well. There's also environmental, social, and governance issues. So there's things like pay equity, laws around equity, gender equity on boards of directors and so forth. So there's a number of factors driving this DEI work. We've actually gotten away from the business case for DEI because it's the right thing to do, but there is a business case for it. You can see here. So companies that really embrace DEI have higher revenue growth, higher profit margins, more attractive new product development, and so forth. So DEI is not just internal within the organization on how you treat your own employees, but it's also your customer base. And not only is your workforce diverse, but your customer base is diverse as well. And for healthcare folks, that could mean patients or clients. There's also a sense from employers around corporate social responsibility. And in fact, some employers, when they produce reports about their commitment to diversity, equity, and inclusion, frame it in the context of corporate social responsibility. Honestly, my colleagues that also do DEI work at Mercer, we were concerned this spring when the pandemic hit that employers were going to just drop DEI. And unfortunately, we had the murder of many Black people and brown people, and the racial and social justice issues that came up as a result of that brought this back to the forefront. And we have many employers now in all industries approaching us to help them in their journey around DEI. So that has been an encouraging development. Unfortunately, it was prompted by unnecessary loss of lives. So let's talk about, as I said, we're going to talk about some key terms just so we all level set in terms of what we mean by that. So diversity here, you can read the definition. This really plays off of that flower that I had at the very beginning. We think about diversity in all its aspects. I think sometimes people think about diversity just from a racial ethnic standpoint, but I mean in all different kinds of aspects. Sexual orientation, gender identity, different abilities, nationalities, and so forth. So think of diversity in the broadest sense in terms of what we mean by that. This is a list of assumptions and values about health equity I think that are really important. They come from the Oregon Health Authority. And it shows that, you could read these. I think a couple that are really important is number 4, equity must be intentionally pursued as a strategy. It does not just magically happen. We have to be intentional about it. And inequities in the population health outcomes are primarily a result of social and political injustice, not lifestyles, behaviors, or genes. So this is causing injustice in the health system, the educational system, the criminal justice system, which results in negative health outcomes. So again, this will be in the deck, but just thought it was a really important way to think about what are the assumptions that we have around health equity. Inclusion. So I love this little visual here, that there is a difference between equality and equity. Equity means that we take into consideration the needs of the population so that there's a sense of belongingness that happens. In this instance, it's height. So the image on the left, yes, we're being equal, but we're not really being equitable. Another practical example in the work that I do in benefits is a benefits manager will say, well, we send out the summary plan description in a PDF to everybody. It's like, well, if someone has vision loss, how do they access that information? Do you make it available on other communication channels like a podcast or audio recording or something? And although that sounds maybe trite, it's true that to be inclusive and equitable, we need to think about the needs of the population. Intersectionality. So this concept came from Professor Kimberly Crenshaw and back in the 80s. And this is the idea is that we're not just our gender or our race or our sexual orientation. We're all of those things together. And I think as human beings, in order to maybe understand the world, we compartmentalize or we classify or codify people into one domain and think, oh, this person's a woman, or this is a Black person, or this is a gay man. And that defines totally who they are, which is not true. We're all those things combined. And so I know some individuals create personas to think about where people are at in their life cycle at an employer, for example. And all that's good. And we need to remember that just one aspect or one demographic does not totally define who we are as an individual. So I just think it's a really important concept to bring up when we talk about diversity, equity, inclusion. Another example of this is, again, when I work in benefits, an employer will put in a benefit, for example, to help support pregnant women throughout their journey of becoming pregnant and having children. And they will say, well, we've addressed women's health. It's like, well, wait a minute. You haven't addressed women's health. You've addressed reproductive health. There are other aspects of women's health that are obviously need to be attended to. So again, it's kind of boiling it down to just one domain or one aspect, which is inappropriate. Yes. Oh, I think we needed to wait a couple more slides. Oops, go ahead. Go ahead and respond.
I'm sorry, David. I'm sorry, Michael. I thought this was, it is the next slide. I apologize.
No, that's all right. No worries. Don't be afraid to say no. Most organizations I speak to say no. You're trigger happy with the polling, Amy.
I know. I like it. We really appreciate your participation.
That's great.
Not the usual double tasking that people tend to do on webinars these days. All right, it does look like we're coming up on a minute, so I will end the polling in about 10 seconds. Okay, countdown begins and ending.
Great. So we see 74% said no, and the provider directory could be at a health system or it could be at a health plan. Only 12% said yes, and a few folks said that they were currently building one. And some said, well, we're talking about it. So that's great. Thank you for responding. Now, let me tell you why that's important. So this very busy chart shows a brief history and overview of primarily the treatment of Black people in the United States over the course of a couple hundred years, starting with experimentation with obstetrical and gynecological procedures in the early 19th century to the Tuskegee quote-unquote experiment, some say public health disaster, to the Henrietta Lacks use of genetic materials without the approval of her or the family. And so there's been, I could go on, there's lack of participation of racial and ethnic minorities in clinical drug trials, as well as with women, for example. So this is just highlighting racism in the medical system. All this to say that this has resulted in mistrust in the healthcare system. And so this has particularly come in light with the identification of effective vaccines for COVID. I think rather than saying, why aren't Black and brown people getting the vaccine, we maybe reframe it and say, our healthcare system has engendered mistrust. How can we overcome that in order to get timely and appropriate vaccines to Black and brown people so that they can be immunized against COVID? So again, this will be in the deck that goes out to you, but and this is not all of it. I mean, we could put up a slide that shows overt racism with Native Americans, and it would look different, but other instances. There we go. So as a result of this, I would say, I think, there's been much work on the patient and provider congruence and the impact of patient and provider racial congruence, particularly for racial and ethnic minorities. It's also true that there is research that shows the positive impact of patient and provider gender congruence, particularly for women. I just saw a study that came out, I think from the University of Minnesota, that was highlighted in the Wall Street Journal, that showed thousands of patients, Black infants, and showed that the infant mortality rate went down dramatically when the infants were delivered by Black doctors. There wasn't as much of an impact on mortality rates for the mother, but infant mortality rates were significantly impacted by having the baby patient and provider racial concordance. There's a study here that I've cited. Some of the other studies have shown that definitely member experience is increased when there's this concordance. There may be positive health outcomes. There is a little bit of mixed outcomes in the literature, but definitely on a member experience, it's typically been positive. That's why we asked the polling question about who offers that information on racial or ethnic identity of the providers, because it is important. And even if an individual does not select a racially concordant provider, giving that patient or member the option to do that is signaling to them that you're thinking about them. And it, I think, gives a sense of inclusivity and belongingness, that it's not an overlooked item. Now, there are issues around sufficient supply of providers, particularly in certain specialty areas and so forth. I think the advent of virtual care has helped increase access. I think also patient and behavioral health provider racial concordance is particularly important. And that actually just came up in a recent episode of This Is Us, for those of you that watched that. That one of the characters, who's a Black man, wanted to find a Black therapist to work with because he felt that that's what he needed in order to make progress with his own recovery process. Anyway, these are 4 dimensions of racism: institutional, policies and practices that reinforce racism; structural, meaning multiple institutions, healthcare, education, criminal justice, and so forth. So the entire structure that is incorporated with racism. Interpersonal, between 2 individuals, and then internally, there can be internal racism. I would say a really good book about this topic that I've read recently is How to Be an Anti-Racist by Ibram Kendi. Professor Kendi lays out a really compelling and very readable book around this concept of anti-racism that I would strongly recommend. And so in a healthcare context, remember, all these things come into play when individuals are trying to access healthcare. So all this leads to disparities. Oh, she's at it again. So the question here is, what are your challenges in identifying health data to identify and address health disparities? So please go ahead and fill this out. And I'm going to talk more about data later.
Getting, again, great participation. Thank you, everyone. We have about 200 people, so I think we should give them a full minute to participate. So we'll close polling in about 15 seconds. About 5 seconds left. Thank you, everyone. And ending now.
Great. So what we see, the top category is lack of access to data. Another one, thank you for your honesty, is organization has not made this a priority. Yeah. Patient reluctance to share data, absolutely. And then regulatory and sample size too small, were way further behind. So lack of access to data is a key challenge. So thank you for answering the polls. I think it's really important when we talk about health disparities is if we don't have the data, we can't identify where those disparities lie. And disparities are inequity or an injustice rather than just simple inequality. Like and it's avoidable. So people have different experiences in the healthcare system. Examples of Black patients report that when they report pain, they are less likely to get pain medications than white people. I mean, it goes on and on. Another one is the infant mortality rate of Black infants. If you account for other demographics, Black infants have much higher mortality rates than white babies. So there's many instances of the health disparities, but you have to have the data in order to be able to identify it and then come up with a corrective action plan or performance improvement plan to address it. So do disparities exist? And I know there are people from all over the country that are on this call. This is from the Office of Minority Health. The state and territorial efforts to reduce health disparities. The last report that I found was from 2015. It's reported state by state and then with national averages. And so you can see this is from selected chronic conditions. And so they have ethnicity, race, and then the totals compared state compared to national. So you can see that there's opportunities in Washington State for improvements. There's opportunities in other states as well. I'm not just singling out Washington State, which is where I am in Seattle. But again, if you don't have access to the data in your own data warehouse or repository, there are other ways of getting at that data to see where you're at in regards to race and ethnicity and chronic conditions. And the next slide would show preventive services per 100,000. I had a client that we got the race and ethnicity data and we profiled it using the same metrics that we use for our annual reporting for this health plan, and found that actually Native Americans were disproportionately high with readmission rates and avoidable emergency room visits, for example. So it's very telling. And now we're going to go back to the health plan and the health systems to figure out what can we do to address the needs of Native Americans. Just for those of you in other parts of the country, in the West, we have, although minority, a sizable population of Native Americans, so the numbers were credible and need to be addressed. So I think it's just really helpful to not get bogged down in data, but just to show that indeed there are health disparities and opportunities for improvement by both by healthcare systems, health plans, and employers. So as a result of this health disparities, there's this concept of weathering. And weathering basically is a physiological process and reaction to what could be called a toxic environment. And so it's like repeated exposure and issues around discrimination, prejudice, barriers, institutional structural racism that do actually have a physiological impact on marginalized populations, whether it's Black, Indigenous, and people of color, LGBTQ, people with disabilities, and so forth. And so we just have to recognize that, particularly in a healthcare setting. And I think of accumulation of weathering results in what's been coined as the allostatic load. And so this is the compounding effect of this weathering process of all these environmental issues impacting individuals who are from whatever minority population have to then deal with. And you'll see in this study that there were 3 factors that were known to contribute: race and ethnicity, gender, and socioeconomic status. And so that's why it's important to get access to the data, because we know that these, at least these 3 attributes, and there are likely others, contribute to this allostatic load, resulting in people being more vulnerable to things like COVID infections or other chronic or infectious diseases. The other aspect when we talk about health disparities and health equity is social determinants of health. And I know I have some colleagues on here that know a lot about social determinants of health. And so these are upstream impacts on the health status of individuals. So social determinants of health are issues like housing, transportation, food desert, and so forth, interpersonal violence, domestic violence, gun ownership, all those kinds of things that impact a person's life because it's where they live and work impacts their health status. An example of this is a study that was recently done that showed that cardiovascular disease is much higher in neighborhoods that have reported higher levels of interpersonal violence. So people are not out walking because it's dangerous where they live. And as a result, they get less exercise and then become prone to cardiovascular disease. Now, I know that correlation is not causation, but just want to point that out. Another interesting aspect of social determinants of health is the concept of food deserts. And there was a study that was done that showed that in a neighborhood that only had convenience stores like a 7-Eleven, I'm not dissing 7-Eleven, I'm just as an example, a convenience store. And when a full comprehensive grocery store was put into the neighborhood, obesity rates did not drop. Well, the reason for that is people had better access to food, but they did not change their meal preparation habits. So it's not just access to food or healthy foods, it's also teaching people how to redesign their meal planning in order to have a healthier diet. So both have to come hand in hand. Luckily, particularly Medicare Advantage plans and Medicaid managed care organizations have been addressing social determinants of health. I know I've been bombarded with Medicare Advantage ads on television saying there's all these new benefits about meals and transportation to appointments and so forth. Employer-sponsored plans are just now realizing the need to address social determinants of health. Also, providers have identified the need to connect with community-based organizations for things like non-medical transportation or non-emergent transportation to medical appointments and so forth. But it definitely impacts health status and results in health disparities when we have social determinants of health that are present. By the way, access to education and access to healthcare also are social determinants of health that negatively impact the health status of minority populations. So this is a wheel of power and privilege. And this can be somewhat controversial, the concept of not just white privilege, but all different kinds of privilege. I mentioned that at the very beginning of this talk, like who am I talking about health disparities and health equity? You know, and as I said, we're all have our lived experience. There's different kinds of privilege. And I give the example where I was on the City of Seattle LGBTQ Commission. We're one of 5 civil rights commissions in the city. And we were preparing to do an interview with city council members. We were preparing our questions. And we had questions about homelessness and the Seattle police and income inequities and so forth. And the question that the people with disabilities had, the one burning question, was the state of the sidewalks in the city, because that was their largest issue with the city of Seattle. And when I heard that, even though I'm an old rehabilitation counselor by background, I realized that I had such ability privilege that I never would have thought that sidewalks were a huge barrier and the burning issue in the city council member election that was brought forward by the people with disabilities. And so this is not to say anyone's had a privileged life. It's meant to say we all come to life with different kinds of privilege, whether it's skin color or education or sexual orientation or ability or disability status. And it's difficult sometimes to see the worldview of others. And so I think that's also plays into why it's so important to have a diverse workforce, and because you also have diverse customer base. And if you have all the same kinds of people sitting around the table, figuring out how to design or redesign a product or a solution or a presentation, if you're all alike, you're going to lose that richness of the diversity and inclusiveness it brings to the table, whether you're a manufacturer or a health system. So I know this is controversial. Some people have a really difficult time kind of taking this in, but I just think it's important to recognize, and none of us are all full of privilege, and none of us are all disenfranchised. We all have different aspects of ourselves. And this also plays into the intersectionality that I talked about earlier, that we're a mix of all these things. And so it's difficult to categorize people, even though we do that because we're human beings, we want to figure out the world. So I love this quote that healthcare equality is making sure that there are no preventable differences in inputs, but it's health equity is making sure there are no preventable differences in outcomes. So that everyone that kind of comes in the door, virtual or brick and mortar, are going to have the same outcome, regardless of their demographics or attributes. That's what we're trying to achieve with an equitable healthcare system. And this image I love as well. You saw the first part at the beginning, equality, equity, and then I love this one about liberation that shows that barriers have been removed. And then inequity has been addressed. We're not there yet, but maybe that's what the vision is for where we want to be down the road, that we remove barriers and that we're aware of barriers, or that we're aware that we need to ask about barriers when we're talking about health equity. Okay, we're coming up on a question. So go ahead and launch, Amy. When we think about the organizational spectrum about DEI, we have these categories. This is a made up Mercer continuum: silent, reactive, proactive, and mature. And the different domains are listed there. You can take a look at organizationally, your leadership, community, metrics, benefits, and so forth. And I think what I would say is that we're all on a journey and we're not static. And that in some areas we may be mature, in other areas we may be more reactive. So glad to see great participation in this one. It's fine to say you're reactive or silent. This is anonymous. It's not going to go back to your employer. So
we're not looking at any back-end information, so completely anonymous. Feel free. It looks like there's still a few trickling in. We'll give it another 10 seconds or so. Okay, I'm going to close the poll now.
So I've done this polling before. This is very high, actually. That 54% believe that the organization is proactive. That's actually great. 36% said reactive, 7% said silent, and 3% said mature. So thank you for responding. I should have clarified that employee resource groups and business resource groups down below in the bottom left, that's what those mean, or diversity councils. They go by different names. And then you can see the other aspects of DEI from an organizational perspective. So this is the flip. Give me a second here, Amy. This is the flip of the organizational continuum. This is the individual leadership continuum. This is actually not from me. This is from Jennifer Brown, who wrote the book, How to Be an Inclusive Leader. And interestingly enough, she came up with these 4 phases, which kind of aligned with what we had come up with at Mercer for the organization. So from unaware, aware, active, and advocacy. And again, I think here we're all on our own journey. And some days I feel like I'm an advocate. And some days I feel like I'm unaware. So it varies from day to day for me. But go ahead and pull the poll up, and we're going to see where you think you're at on this continuum of unaware, aware, active, and advocate. I think you probably would not be on this webinar if you were unaware. So very few people will probably be unaware.
Again, thank you everyone for your participation. We'll let this one go for a minute. So you have about 20 seconds left. Although we did just slow down significantly, so maybe we'll stop it at the 50 mark. We'll give it 5 more seconds. Okay, I'm going to end the polling.
So it's pretty neck and neck. 43% said you were active, 40% said aware, and 17% said advocate. That's great. Thank you for responding. I have to tell you for myself that it varies from day to day. The day that I had no realization that sidewalks were the big issue for people with disabilities, I felt like I'm in phase 1. And other days I feel like I'm an advocate. And how you express that's going to vary, obviously. It may be reading, it may be going to Black-owned stores, it may be writing, it could be all different kinds of things of how you express your activism or your advocacy in this area. I'm showing this as well around what are some inclusive leadership traits. This is also from a book about the six signature characteristics of leadership. You can see what they are. I think one of the recurring themes throughout all of this is the ability to listen and the understanding or recognition that there's a lot to learn, kind of that awareness, cognizance, the curiosity, learning, having some kind of cultural intelligence. I would also say that this is particularly important for healthcare providers to incorporate these characteristics into their work, assuming you have a diverse patient or client caseload. And then the idea of collaboration is also important. Courage means being able to say, I was not aware of this. Or if a lot of people are like afraid to make a mistake of how they talk or so forth, being courageous and said, I'm sorry, I used the wrong term. Words are important, and labels are important. So I just throw that out there. Highly recommend the book to learn more, both this one and the one by Jennifer Brown, How to Be an Inclusive Leader, as great ways to learn more about how inclusivity can be brought into your own leadership style. I think if it's an organization that's going to really address health disparities and health equity, you must get the commitment and alignment with your leaders in your organization, or it will not work. And we know in healthcare that's true of any major initiative. If you don't have the commitment from your leadership, the initiative will likely fail. And so you have the commitment of the senior leadership. I also think that the middle management folks that are usually tasked with implementing whatever initiative is going on need to be definitely involved and supported and educated about how to do that. And so it's great to have statements that come out from CEOs about Black Lives Matter movement, or for people with disabilities or LGBTQ, but there's got to be action that goes along with that. And it can't just be senior leadership telling, go forth and do it. There needs to be clear, demonstrated methods, processes, communication channels that are set up to provide that ongoing systematic approach to diversity, equity, and inclusion in an organization. So I know we talked about data before. I want to talk about it a little bit more. So when we already talked about health disparities, you got to have data to look at. And I'm going to talk about the data from both members or patients, as well as providers, and then some new solutions and services involve coaches. Health coaches, in my experience, typically are unlicensed individuals who are providing support for individuals who are subclinical or don't yet have a diagnosis, but need some kind of support, particularly in the area of, for example, like mindfulness or preventing behavioral health conditions. So there's been a proliferation of health coaches in different benefit solutions, particularly. For those of you in healthcare, you could think of community health workers as a coach, as an example. So can be very important to the team. And so we talk about member data, and I have a bunch of things listed there. I think honestly, gender is typically in databases. Race and ethnicity may not be, and I saw from the poll that it wasn't for many people. That's typically collected on a voluntary basis by an employer. Many times what I'm finding is that's not transmitted to the health plan or to the database that benefit people work in. I assume the health systems collect that data on a voluntary basis. But I would say that other data elements need to be collected. And this is, we're going to be on a data journey here around DEI, sexual orientation, gender identity, again, all on a voluntary basis. Will give us a richer database in order to identify marginalized populations and what their needs are based on analysis of health disparities. The same is true with providers, a little bit different with providers. There's the demographics of the provider, but then there's the competencies of the providers for the health coaches or whatever professional, paraprofessional we're talking about. My experience with cultural competencies, identifying particularly healthcare providers around cultural competency, is usually done in one of three ways. One is self-attestation. So the provider has to pledge that they are committed to following certain values or guidelines in the diagnosis and treatment of certain individuals. There's also cultural competency. The second way is required training and usual testing at the end to verify that someone does have that knowledge. The third way, although I've not seen very many organizations do this yet, is data analysis. So they would know have access to the data on the patient or client population they're working with. And then they would look at the healthcare quality metrics, both process and outcome measures, to see if that provider has had a positive impact on that identified population. So those are three ways that I've seen cultural competency kind of defined by health plans or health systems. I also put in here in terms of data access channels, again, particularly for individuals with communication disabilities, hearing loss or vision loss. Also accessibility for people with disabilities for office visits. I was actually looking for a dentist for my mother and was pleased to find that a provider directory actually indicated whether the office was accessible. And one of the dentists I picked said that they were not. And so I called them up and I said, hey, you're not accessible. And they said, oh, that getting into the dental office is accessible. But if someone's a wheelchair user, they cannot then transfer them into the dental chair. So that was helpful to know. But anyway, that's another item that could be included in a provider directory to be more inclusive. We're going to take questions at the end. I know some people have putting comments and raising their hand. So we're going to get through the entire presentation and we'll field questions. Thank you. So there's several strategies to address quality inequities and disparities. First, reporting from a standard set of quality metrics. This is around health disparities. So rather than creating yet more quality metrics, which would be the bane of the quality directors at healthcare organizations who are already inundated with literally hundreds of quality metrics, let's use standardized quality metrics, but look at them from the lens of race, ethnicity, gender, sexual orientation, gender identity, socioeconomic status, whatever demographic we have access to. So that we're not recreating the wheel, coming up with yet more quality metrics. We want to monitor for unintended consequences. So if you do this over here, does something inadvertent happen over there? And then we want to strive for improving equity. And I would say both for preventive services as well as chronic conditions as well. I love this graphic from the National Quality Forum around the roadmap for quality metrics in health disparities and health equity. I think that plans and purchasers, employers can look at, do they incentivize providers based on the ability of the providers or the health system to identify and then address and improve health equity? And maybe we start with just identifying the health disparities, but ultimately we want outcomes. We want improvements in health equity, achieving health equity. It needs to be identified and prioritized in the organization, whether, again, that's the plan or the provider, the health system, and then implementation with evidence-based interventions to reduce disparities, which can come in a variety of different forms. It can be how you communicate, what images do you use, do you have a dedicated team for a particular population, and so forth. Okay, so we've talked a lot about what we're dealing with, lots of terms and definitions: diversity, equity, inclusion, intersectionality, allostatic load, weathering, and so forth. We've shown that some data indicates that, at least in Washington State, and rest assured in other states, there's an opportunity for improvement in certain quality metrics. So what's the framework? So the framework that I've been using in the work that I do around mainly benefits is understanding where you're at today with whatever available data you have, identifying gaps, and that can be a variety of forms: looking at your data, as we've been talking about, making sure that the data is available for analysis. It can be doing an assessment of a benefit provider around different domains of their organization and how they address diversity, equity, inclusion. Talking to the identified individuals, and that's where going to your business resource groups or employee resource groups or diversity council, whatever they're called. And if you don't have any of those, I'd strongly suggest you have one, at least one diversity council, to have that voice of the employee to provide input, not only for benefits, but for all sorts of kinds of policies and procedures in your organization. And then once you've identified what the strengths are and the opportunities, you get the feedback from your employees or your patient population or clients or whomever it is your customers are, then it's implementation. Hopefully you can do that without recreating the wheel. Sometimes it requires to go to another organization if the current vendors or suppliers you have are unwilling or unable to provide that service. An example I can give you is I had two different clients that with two different employee assistance programs. These are traditionally 1-800 numbers you can call for behavioral health, but also for education and for other resources. One EAP, I asked, what do you have around white privilege, racism, anti-racism, other topics? And they said, oh, we have this whole library. I was a trusted advisor to the client so that you can listen to any of them. They're recorded. We could do them live. It was amazing. I went to another EAP. They had literally nothing on any of those topics. And so the second one, it's like, I think you need to go to another EAP. They're not poised to help you right now. And so anyway, that's not the intent of, at least when I do this work, to kick out a vendor or supplier. But in some instances, if they're so far behind, that may be what you have to do. So just some questions to get you started with diversity, equity, and inclusion, because this goes beyond human resources. It's the entire organization. It's who's your senior leadership, who's your board, your supply chain. Are your suppliers diverse? Looking at your data, what data do you have available? We talked about that. And then leveraging your partners, your suppliers, your vendors, whoever those might be, to help you figure out what they can do, and always listening to your employees or your patients or your clients about what's important to them. They have to be at the center of this so that we don't have a bunch of like-minded people thinking they're doing the right thing, but actually really not helping the identified subpopulations that you're trying to assist. So, what are your biggest barriers to achieving health equity within your organization? And check all that apply.
Yes, we did have a comment. This is one, not all of the questions, because we were asking people to participate and indicate where they were on a continuum. Not all of the questions you were able to choose more than one, but this is one where you should check all that are relevant for you or your organization.
Yeah. Thanks, Amy.
No problem. Getting, again, some great participation. Thank you, everyone. I think we'll go for another 15 seconds. So we'll go for another 5 seconds. Speak now or forever hold your peace. All right, closing the poll.
Okay, so we have other competing organizational priorities as top. Neck and neck are lack of access to data and lack of resources, staff, training, program analytics, and so forth. What's interesting to me from this poll is lack of customer demand is the least. So in other words, I would interpret that maybe there is interest from customers um, in DEI. Maybe not, maybe I'm reading into that question. This is very helpful. So it's got to become a organizational priority to make it happen. Leadership's got to be there, and leadership has to commit resources to make it happen because it just does not happen all by itself. Remember that slide that had the key assumptions about diversity, equity, and inclusion. So one way to look at DEI, and this is more for employers with their benefits, but I'm going to address it from a provider perspective here, is looking at different domains of your insurance carriers or your other benefit vendors, employee assistance program, disability carrier, digital health solution, and so forth. So organizationally, what's the composition of the senior leadership and board, provider network? Do you have provider directory information with race, ethnicity, gender, and so forth, or cultural competency? Your member services, so that's like call centers. Are they trained? Do they know how to help navigate people to community-based organizations if a social risk or need comes up, or make a referral to a clinician? Reporting, so that would be on health disparities, health equity. Communication channels are things like how does the organization deal with the needs of people with hearing loss or vision loss? Do the marketing materials, both hard copy and the web, represent a diverse population? So you wheelchair users, Black, Indigenous people of color, same-sex couples, etc. Specialized services. I've seen some health plans have specialized teams, for example, for gender affirmation treatment that have been highly effective because that team really knows about gender affirmation treatment from a clinical perspective and a benefit plan perspective to help support them in their transition process. Training and development of the staff, whether they're a customer service rep or a clinician, making sure that your staff is trained and not just a one and done training, but ongoing comprehensive. Data analytics, we've talked a lot about that. The clinical clinicians, are they systematically, for example, screening for social determinants of health, and then do they have resources to navigate those individuals to appropriate community-based organizations? Educational programs, that would be applicable, for example, for an employee assistance program to address the needs of individuals, for example, like the coming out process, or surviving a hate crime, or surviving racial trauma. What do they have available to them? So that's just one way of thinking about how to look at the organization. The Institute for Healthcare Improvement also has a framework. This is more applicable to healthcare providers. So, so this is from left to right, making health equity a strategic priority by getting the commitment of the senior leadership and having a governance committee and a budget and resources to support that initiative, deploying specific strategies to address the determinants of health, decreasing institutional racism within the organization. So training on implicit bias and related topics, having a physical space that's accessible, and of course now virtual. But again, remembering with virtual care, making sure that you address the needs of those with hearing loss and vision loss. And then developing those partnerships with community-based organizations. Like in Washington State, the Accountable Communities Health we're trying to do is really important. So that's the framework that IHI, or the Institute for Healthcare Improvement, has given for healthcare organizations to achieve health equity. Another framework is from the American Hospital Association's Institute for Diversity and Health Equity. They have these 4 domains of a dashboard. So data collection, stratification, use. When I was doing this, it's like data kept coming up over and over again. And so they also have race, ethnicity, and language, SOGI, or sexual orientation, gender identity, disability status, social needs, cultural competency training. Again, must be ongoing. There's actually been studies that show a one and done training For example, unconscious bias has no impact on cultural diversity in the organization. Strengthening community partnerships, the community-based organizations or CBOs, that came up in the IHI one. And then again, diversity, inclusion, leadership, and governance also in the previous one from the Institute for Healthcare Improvement. So there's a lot of synergy between all of these models or frameworks, which I thought was really interesting. The Healthcare Payment and Learning Action Network, which is a great resource, and all of these will be in the back of this deck. They identified it, they call it Healthcare Resiliency Framework. And within that, they have a framework for promoting health equity in healthcare. So they have the short-term actions on the left and the long-term actions on the right. And I love that the fifth bullet down include Black, Indigenous, people of color, providers, as well as provider organizations serving underserved populations in alternative payment models. Making sure we don't have unintended consequences. If you remember, that was one of the 3 things to look for. And then also the last one, which is get the patient family perspective. What a concept, talking to the patients or the clients that you serve to see where their needs are, what their barriers are, and what would help them in getting timely access to good quality healthcare services. So those of you that are on the call that are service line managers in health systems, I came across this concept from Out Healthcare Link, I think it's called, and the citations on the bottom, lgbthealthlink.org. And they did some listening sessions to individuals about what they call best and promising practices. And they focused on cancer. So this is just one example of a service line. So some of you may have cardiac or musculoskeletal or whatever. But they found these were cross-cutting themes throughout the entire continuum of cancer treatment, prevention, treatment, and outcomes. So SOGI data, LGBTQ culturally competent workforce requiring training of both clinical and administrative staff, the whole healthcare system being culturally competent. So that's things like having forms that collect SOGI data, allowing a gender non-binary category, allowing for same-sex couples, etc. Patient information education, so that the materials you have, again, both online and hard copy, would be representative of same-sex couples, as well as families with same-sex parents and children. And then diversity and intersectionality, remembering that whole concept of folks are not just their sexual orientation or gender identity, they're all of those things together, right? Then this was a really helpful continuum. Now, the bullets down below are not an all-exhaustive list. The document that I took this from had many, many more, and it was too much to put on the slide. So they have 6 phases here. I might simplify that to 4 when I talk about different health conditions. So prevention, screening and diagnosis, I usually put together. Treatment would be another, and then the last 2 could be combined, kind of aftercare and return to function, return to work, again, from the lens of an employer. So you can read some of the ideas here, but I thought it was a really helpful framework as you go about taking a look at DEI. If you're a service line manager or director, or if you're in a health system that specializes in a particular condition, of like sitting down and using either the 6 buckets or 4 buckets categories and figuring out how can we make our service line from all the way from prevention all the way to aftercare as inclusive as possible. This happens to be focused on LGBTQ individuals. You could apply another racial and ethnic minority, people with disabilities, etc. But I just thought it was a really helpful way to think about the framework for a healthcare service line, about how they go about creating the entire service line from front door to back door, if you would, as inclusive as possible. So I think, Amy, this is going to be our last slide of the day.
Other than resource slide, yes, that is.
Yeah. Correct. Oh, yeah. Resources. I guess I'll do that too. Sorry. So make decisions about what you're going to do with your senior leadership. Identify your success metrics. Don't just leap to some solutions. leadership engagement, know who your key stakeholders are. Again, I'm going to say the patient or client or member voice is really important, and how will you do that? Do your gap analysis and then report. Be very transparent in the reporting to demonstrate progress and also the opportunities, improvement opportunities that you may have identified. There's lots of health equity resources. Because many of you are from Washington State, I just thought I would list a couple from both the governor as well as the Department of Health. Multicare has a great health equity toolkit. I highly recommend. There may be some people from government agencies. So the Government Alliance on Race and Equity was a helpful resource. For those that are from health plans, AHIP, America's Health Insurance Plan, has some great resources. National Alliance of Healthcare Providers Coalition had a series of webinars this summer on different aspects of race, health, and equity. I was a panel participant on the one on social determinants of health, but they're recorded and you can access them free of charge. The National Alliance to Impact the Social Determinants of Health, which is a mouthful, is another great resource to go to. The Seattle Office of Civil Rights has a racial equity toolkit, which I am familiar with, and they use that toolkit in all their decision-making for the city. So those are just some. Also at the bottom, you'll see the journal article citations or books that I cited for some of the slides that you can look those up as well. So with that, we can go to Q&A. And I wonder if I should stop sharing and so we can see people's faces. I don't know. What are you thinking?
Sure. I think that it will just be you and I.
Oh, okay. Gotcha.
Okay. There are 200 people online, so there's no room for that on anyone's screen. Okay. So thank you so much, Michael. That was a broad overview and such a depth of knowledge. We really appreciate you spending your expertise and sharing your expertise with us. We did get some questions in, so I'll dive right in. The first is, I find that the least discussed DEI element is diversity of thought process. It's kind of an interesting question. It stems from background, education, culture, age, and other factors. How do we get our teams to think and talk more about this?
That's a really good question. I think ongoing training and awareness is where you start. Mm-hmm. And I think when we talk about diversity, equity, and inclusion, it's really a broad topic. It's race, ethnicity, gender, neurodiversity. I don't think I mentioned multi-generational. I've done a training session on multi-generational. It was really interesting. What it came down to was how we communicate. Different generations, although it's a stereotype, have different communication styles. So I think what it boils down to is communication in terms of what this individual is bringing up, and just recognizing different communication styles, so introvert, extrovert, neurodiversity, and then making that okay to have different ways of communicating.
Absolutely. How does the notion of concordance affect resegregation and lack of knowledge regarding different groups? This was toward the beginning when we talked about concordance.
I'm not sure if I quite understand the question. I think the point is if we at least make the information available to people around the race of a provider, that they can then make that choice. Right. Due to the lack of racial and ethnic minorities in particularly some medical specialties, that may not always be possible. So I think we still need to provide training and cultural competency to white providers or others. I think it's really important to allow for that choice to happen so that patients or clients can make their own determination about who they want to see.
Sure.
I think also organizations can also, if you would, tout their cultural competency training and show results based on data. If you can show that all of your providers have great outcomes with certain populations, there's power in reporting out on data.
Absolutely. It really tells the story of what we're trying to get at here.
Yep.
DEI is such a big topic. So really just getting to the starting point, how are organizations best, how would you suggest they get started if they're just completely brand new, they recognize this is a topic that they should address and want to address, they have the buy-in from leadership, or maybe that's even not there yet, the buy-in from leadership. Just what are some first steps that you would recommend?
I think it has to start with leadership.
Okay.
Because if you go off and try to do something, you don't have the buy-in leadership, you're not going to get the resources, you're not going to get attention, and it's going to fail. And so
Yeah.
you have to get leadership. And that may be uncomfortable at times. How you get their leadership attention could be data to show, okay, we have, I'm just thinking from an HR perspective, okay, we're recruiting lots of Black people, wheelchair users, or so forth, but they're not staying. Right. And turnover is costly. And so, unfortunately, for some C-suite leaders, you have to show the return on investment or the financial impact of not doing DEI to get their attention to actually take action. So it depends on the organization, like what's going to speak to the senior leadership, but you have to get senior leadership engaged or it's not going to be successful. And then from there, it's looking at your data, figuring out the multi-year, coming up with your strategic plan, and realizing you can't do it all at once. Yeah. You have to stage it.
And when the data, let's say you're a smaller organization, you don't necessarily have the resources to provide some robust data. Are there any other strategies you would recommend?
I think if you don't have the data, you have to assume that there are health disparities that need to be addressed. You have to do some looking at, even if it's not hard data, like anecdotal data about your patient, client, customer population, for example, or your employee population. You likely have information about your employee population, about the demographics, and then do listening sessions with employees or the members or patients or clients, or customers, whoever they are, to find out what their needs are to come up with your strategic roadmap.
Sure. So maybe like brown bag lunches and survey, customer surveys, patient surveys, as well as employee surveys. Okay.
Yeah. And making it safe so that it's maybe somewhat anonymous so that they feel comfortable talking about the barriers that they have in the organization.
Absolutely. Especially if it is a situation where leadership maybe doesn't have the buy-in yet, that safe space may not be quite there.
Yep.
What is your advice for framing organizational policies that allow people to choose their provider without supporting racist tendencies? For example, someone says, I don't want an Asian provider.
Yeah, that's a hard one. You run that risk. And I think that's the reason why up until a year ago, provider directories did not have that information. The world has changed as a result of all the experiences this country has had and continues to have. That can still happen, honestly. But rightly or wrongly, we have a provider shortage, particularly in primary care. And so sometimes patients or clients will be required to go to the provider that's available to them. Yeah. So that is a risk that you run. But the risk that you run by not doing it is you're not attending to the particular needs and preferences of other patients.
Yeah. How does an employer incorporate employees into the DEI strategy and initiatives?
Yeah, so that's what I was referencing: business resource groups, employee resource groups, diversity councils, some employee group that's representative of a diverse population to get their input. If you don't have one, I would suggest that you form one. There's some guidance out there that you can find around best practices with employee resource groups or diversity councils. You cannot, the challenge though, I will tell you, with BRGs, ERGs, diversity councils, is usually it's at the side of their desk. It's like that kind of almost like extracurricular. They cannot be responsible for implementing the DEI strategy. They can be the voice that you can listen to as you form your strategy, but they're not the implementers. That's got to be at the organizational level. If you're large enough, you can have a chief diversity officer, for example. In some instances, a HR leader. But it can't just be in HR. It's got to be throughout the organization. But that's how I would respond.
And I know that we have the resource slide, but do you have any favorite or recommended trainings or training organizations to sort of tackle the implicit bias issue? I know that
I do not off the top. Sorry.
No, that's totally fine. I know that puts you on the spot a little bit, but
I think I might be able to get that to you, Amy, and send it to you later.
Absolutely. Yeah. Just as a reminder to everyone, we will be sending out slides in the recording. And so we'll sort of look into our toolkit of resources and send out anything that would be relevant.
Yeah.
All right. How can organizations review policies to detect drivers of institutional inequities?
That's a really good question. I think if you start again with your diversity council or VRGs or ERGs, they can tell you. For example, I'll give you an example. So a transgender individual, I'll give you two examples. What's the process for changing their gender in the HR system, which can be an enormous struggle. And again, sounds like not a big deal, but can end up being a big deal. Or a related one is someone who identifies as gender non-binary, but the HR system requires you to choose male or female.
Right.
There's actually studies that show that misgendering, in other words, calling someone or requiring someone to be labeled as the wrong gender, actually has health results, raises blood pressure, anxiety levels, and so forth. So that's one kind of domain. The other is having a very difficult or unclear process for reasonable accommodations for people with disabilities. I see that as well, that there's a lot of hoop jumping that has to happen. It's not clear how to get an accommodation, and particularly for people with behavioral health conditions. It's a little simpler when someone has, a back problem and you get a sit-stand desk or a pedestal or whatever. That's a little more straightforward. But even for that, I've seen in organizations, the reasonable accommodation process, like HR kind of goes, well, I don't know, it's just whoever happens to grab it. And then and then that signals to somebody like, oh, they're not really taking this seriously, and I can't get my needs met. So those are examples. If you have a forum of like a diversity council that you can go to and ask, because if it's a safe place to talk, they will tell you what policies drive discriminatory kind of activities like that. Absolutely.
What are some of the biggest challenges with benefit vendors in achieving DEI?
Well, lack of awareness is one. Their systems is another. So by that, I mean the example again about gender, that there's like only male, female, and someone identifies as gender non-binary. Another system related is my favorite, the provider directory. And provider directories, rest assured, I understand, are the bane of the existence of health plans, but to get them to have demographic information about providers is an enormous undertaking. I understand from, for example, my health plan colleagues. So that's a barrier. Technology is a barrier. So if they've built a website or they've built an app and they've not taken into consideration people with visual impairment, it would be an enormous cost to them to adapt it for people with visual impairment. They hadn't really thought about it. And again, that comes back to this idea of privilege, like just not having a perspective that would impact certain users of a service. So those are some that come to my mind. Although I have to say that I've done probably a dozen or more benefits assessments with benefit vendors, carriers, and other benefit vendors. And they've actually been pretty positive in completing a pretty exhaustive questionnaire because they realize it's important to their client. And plus, what the account management people tell me is that this will tell my employer, like, we have to be ready to answer these questions because the market is asking about them. So they have to get organized around this information.
Meet that need.
What's that?
To meet that need that is arising. Yeah.
That's right. That's right. So it's not just some kind of, joyride here. Like, actually, it's being driven by customers.
Right.
I will say our own organization's gone through a DEI assessment. We've been asked questions on certain teams, the composition of our team from gender, race, how much time we spend, and so forth. So none of us are immune. We're all on our own journeys around that. So anyway.
Were the results of that surprising to you as a somewhat of an expert on this within your own team?
No, it wasn't surprising, actually.
Okay.
And it's been helpful when I talk to insurance carriers or other healthcare organizations or benefit vendors. Like, we're all, it's like no one can be living in their ivory tower. We're all in this together, right. And no one has it totally figured out, right? So we all have to be prepared to answer these questions, which may be difficult at times because it points out gaps.
Absolutely. And we've talked about this and touched on it in some of the answers that some of the questions and answers that we've had in this dialogue, but can you address maybe a little bit further some of the fear that leaders might have in addressing DEI and sort of strategies? And, we've talked about allowing ourselves to be comfortable with being uncomfortable and just sort of expand on that a little bit.
Yeah, I think senior leaders have to be brave. Because they have to be willing to say they're going to say the wrong thing or use the wrong language. I was in an internal training session at my own company, and people are like, "Oh, did I say the wrong word?" It's like, it's okay if you say the wrong word, own it and say, "Thank you for letting me know," and move on, and then don't use that old term again. But you have to have a culture that it's okay to make mistakes, and actually not even just DEI, but an organization where it's safe to make mistakes are going to build better products ultimately to allow folks to fail is actually a really good sign in an organization to grow, not just with DEI, but product development and technology and so forth. Yeah. So you have to have that culture. And that context in order to make progress.
Yeah, I think that is so true. I wonder if we could talk a little bit more about how and the best way to identify and address disparities in healthcare. I know that that's a very broad, and we could have a whole nother webinar just on that.
Yeah, I think I kind of touched on it. One is to identify what are the quality metrics that you're going to look at. I know that providers are really burdened with reporting quality metrics. I remember talking to this one quality director at a large health system in the area, and they had like 400 quality metrics from Medicare, Medicaid, different insurance carriers, and so forth. So let's reduce the burden of reporting, hone in on what we think that the top metrics might be, nationally recognized metrics that you're already reporting on, and look at it through the lens of race or ethnicity, gender, or what have you. It all comes down to data, Amy, and having access to that data. But I would just say don't reinvent any new quality metrics. Use the ones you already have, because we want to lower the blood pressure of the quality directors at health systems. So.
Yeah, and so the rest of the comments are sort of asking to look at the slide of resources. So I'll be sure to get those slides out as soon as possible, but I think we can give people 5 minutes back in their day. And just, again, thank you for sharing your time and your knowledge base with us. And for the audience, if there's anything else that we didn't touch upon, please feel free to reach out to Michael or myself over the next bit of time to address anything else you'd like to cover. So thank you everyone for being with us, and we will talk to you soon.
Great. Thanks everybody.
Bye.
Bye.